Great. I am so excited to introduce this new branch of culinary medicine to you. I think it's really important to kind of keep in mind that foods consumed away from home represent about a third of what most Americans eat every week, right? So if you think that there are 21 eating experiences you can have in a week, right? So 3 meals a day, 7 days a week, 21. I can still do math. And that doesn't include snacks. Almost 6 are eaten away from home, and that includes all Americans. And when you tease out by different age cohorts and a locality, it actually goes up for urban. People who are sort of 35 to 44, they seem to be the biggest eater-outers. And with the largest growth in that area in what we call fast casual. So fast casual is like your Panera, your Chipotle, right, versus quick serve, which is what we would call fast food. Quick serve is, your McDonald's, Burger King, etc. Those have had great growth as well, but it's that fast casual arena that has had the greatest growth in the past 20 years. And I think there's a place there, a big place for chefs, right? This is food that is presented as fresher, better, somehow healthier, but we still know that that is still associated with people who eat, those 6 or more meals at places like that a week, higher BMIs, much lower fruit and vegetable consumption, which we know is problematic, and that in general those meals are associated with higher sodium, higher saturated fat. And so the idea or my goal is to get chefs to learn how to prepare food differently. And I think that goes for chefs in any area of food service, right, from hospital to long-term care to fast casual to fine dining. I think there's a place for this knowledge that chefs are generally lacking. So I'm going to introduce our speakers all, and then I'll have them each come up and speak, and then we'll open it up to questions. So those little cards will come around as usual. All right. So I need to use my cheat sheet to introduce because I'm not a memorizer. All right. So our first speaker today is Dr. Aggarwal. She comes to us from the University of Florida, Division of Cardiovascular Medicine, and her focus is really on promoting health through good food, particularly plant-based cuisine. And in fact, she ran a program to convert the hospital food to 100% plant-based. And I know for me, as a dietitian, the hardest thing for me that I fought when working in the hospital was the food service. So it was like, my chef brain would be horrified, and my dietitian brain would be even more horrified. So I think that is definitely a place that we really need to address how we, if I'm going to say to someone, you've just had this quadruple cabbage, eat better. And yet I serve you food that's maybe not better and maybe doesn't taste good. So then you think, well, healthy food tastes bad, so I'm not eating it. And so I think that this is a great place for us to really focus and start to make that change. So, Dr. Aggarwal will speak to us about that program that she developed. So, Dr. Aggarwal. Turn this one off.
Good morning. I'm impressed at you up on this early morning. I was just in pajamas, so I had to skip my run for this, so this is serious. It's good to see you all. Thank you, Dr. Harlan, for having me here and for that kind introduction. So I will be talking about the changes we implemented at the University of Florida to introduce new foods. Yeah, go ahead, please. So these are my disclosures. So the goals of the talk today will be to talk briefly about the impact of diet on heart disease. I know you've had 3 days of that. You don't need me to tell you that plants are good. We're going to talk a little bit about the state of nutrition and healthcare systems, and then we're going to just talk about the most of this talk is going to be on discussing how to overcome the obstacles in changing the food system and how to overcome those obstacles. So why am I here? So I'm a preventive cardiologist. I'm board certified in 4 specialties of cardiology. I say that because it's been a long road. But the part of the road that I'm most fascinated and most intrigued by is my last bit of training, where I focused mostly on nutrition and advanced lipids. So people come to me because they have 3-vessel heart disease, they have had or need CABG, they need stents, and they don't want to get it, or they got it and they want another option. So I advocate a advanced and aggressive medical directed therapy plan along with a whole lifestyle plan. I teach them how to exercise, walk, move, yoga, meditation, and I teach them how to eat. But I'm also a researcher. I really focus on how to how to understand, is olive oil good? Are fruits really good? How many fruit? Well, that one's a no-brainer. But what about, how many nuts? What's flaxseed? What about omega-3? These are the questions that I'm interested in, how they impact heart disease. I'm a mom. I have 3 children, and my story starts actually after I had my 3rd child. I'm an athlete. I'm proud to say that I'm a triathlete. I love to run. It's my favorite thing to do to relax, but I'm also a patient. 10 years ago, after I had my 3rd child, I had 3 children under 4. Anyone who knows that knows what that's like. I had one baby I was carrying one baby was nursing, and one baby attached to my leg. So that's how I lived for a long time, because I felt like I had to work against the clock because I wanted to have all these kids, but I had to wait until I finished my training. 3 kids under 4, I started manifesting disease. So after about 4 weeks or 6 weeks after I had my 3rd kid, I went from being this active runner to being unable to climb the stairs. I was diagnosed with a debilitating form of rheumatoid arthritis. I was told that I had an incurable illness, that I'd be on medications for the rest of my life, and that I just needed to, quote unquote, get used to that. Being a doctor, being told by another doctor that makes you feel small, makes you feel humbled, makes you feel very sad and alone. But that's not a new story, a doctor becoming the patient. But most important for me, because it was life-altering, it made me realize that I didn't want to be that person. I didn't want to just take medications, and I didn't want to be the doctor who just gave out medications. So I started going around the country. I learned from physicians and scientists all over the country. And to learn about nutrition and lifestyle and try to understand how food impacts your body, and actually realize, oh my God, it actually makes a difference. So it's not just in cardiology we tell people that you should exercise better and you should eat better, but I wanted to understand what to do that. I'm sorry, I don't know what's happening here. That's sort of funny. Okay. Okay, that's because I woke up too late for this. I spent this time doing this research, went around, started doing research of my own. I'm proud to tell you that about 9 years ago, I came off all of the medications that I was started on for rheumatoid arthritis, and I haven't looked back. I went back and did my first triathlon. I became the best athlete I've ever been after I got sick. I tell that story because I think many of us have been sick, or many of us have family members that have been sick, and it's hard to realize that there's so much you can do and impact your health with changing your diet. So what do we know? We already know that dietary risks are the number 1 cause of mortality and morbidity in the United States, and that's primarily driven over, if you see above tobacco now, you see dietary risks. And that's primarily driven by heart disease. So most of our patients are dying of heart disease primarily. That's in the United States and in the world. It's men and it's women. What's wrong with our food? I'm not going to go through this too much because we know this. We know this. But we know that it's high in red meat. It's high in refined grains, processed foods, high-fat dairy, desserts and non-nutritious calories, specifically high-sugar drinks. 0.9% of adolescents and only 2 to 3% of adults obtain their daily recommended fruit and vegetable intake. Every time I read that, it blows my mind. I'm from the South now. I'm actually from the North, as I'll tell that funny story, but I live in the South now. And we know that eating a Southern diet is associated with increased risk of heart disease, kidney disease, and stroke. It's not that the food quality that we're eating is poor, but the size has gotten so much bigger, isn't it? The burgers used to be 4 ounces in the 1950s, and now they're 12 ounces. The soda's gone from being 7 ounces to now being 42 ounces. But we know that diet works, and I'm not going to repeat stuff you've already learned and you already know, which is basically that if you change somebody's diet towards more of a plant-forward diet, so mostly fruits and vegetables, Mediterranean plus minus, which is fundamentally a plant-based diet. And if you put people and move them away from a standard American or a standard Western diet, you make them better. Whether that's with a little extra olive oil or with extra nuts, I'm not going to hash that part out in this conference, but to really focus on if you move people away from the Western diet and put them on a plant-forward diet, you make them better. So this study was the PREDIMED study that was done in 2013 and basically shows years on the x-axis and total mortality versus heart attack, stroke, and death on the top graph, and shows that when you change people's diet, there's a 30% reduction in that composite endpoint of heart attack, which is MI, stroke, or cardiovascular causes, and that was primarily driven by strokes. That's not a small number of patients in that study. It was one of the best nutrition studies that was done because it had 7,500 patients, and it was primary prevention. So it was patients who were high risk for heart disease, but who didn't actually have known heart disease. What was most interesting to me about that study was that when you look at the people who were eating that Mediterranean-style diet, the people that were eating the most vegetarian pattern. So if you see here the quintiles of the pro-vegetarian pattern, so number 5 being the most vegetarian, and this is mortality rate on the y-axis, the people who ate the Mediterranean-style diet, but the most plant-based of that group actually had the lowest mortality. So many people say that diet works, but do we actually have data to show that when you make a dietary impact, it can actually improve your risk? We all have patients that say, well, my dad had a heart attack at 45. I just accept that that's going to happen to me. Well, is that true? Are we destined to have illness because our family members had it? This is one of my favorite slides of all, which talks about, it comes from the New England Journal, 2013, if I recall, genetic risk on the x-axis and calcium score on the y. So we use calcium score a lot in cardiology because it's a marker of atheromatoous plaque in your heart. And so if you look at the higher the number, the more the plaque. And then you can see in blue, you can see favorable lifestyle. In red, you can see unfavorable lifestyle. And then you see low, intermediate, and high risk. So what you can see on the low side is that if you have low genetic risk, I don't have a lot of family history of heart disease, but then I have a poor lifestyle, red, then my calcium score will be 31. But if I have a low genetic risk, and I have a good lifestyle, I can have a calcium score at half of that, at 15. So let's look at the high. So people who have a high genetic risk, so that means mom had a heart attack at 45, dad died suddenly at that same time, that high genetic risk, and I eat poorly, well, my calcium score will be 64. But if I change my lifestyle and have a good lifestyle, I can reduce that risk by 50%. That's 50% just by changing lifestyle. So we know this. In 2019, the American College of Cardiology, American Heart Association put together guidelines for prevention. And they said class 1 indication, which means like you got to do it, means we put in there that says a diet emphasizing the intake of vegetables, fruits, legumes, nuts, whole grains, fish is recommended to decrease ASCVD, which is heart disease risk. We put it as a type 1 indication. That also prompted then the American Medical Association to put forward hospital initiatives to say, we need to do better. And so let's change. So the AMA encouraged healthy food options, including low sodium options and plant-based options in the hospital system. And this is something we're really proud of. So how are we doing? Because we know that dietary change works. We showed that the genetic risk, despite genetic risk, your lifestyle can change. We even changed our guidelines to impact and say that, well, we need to eat more plant-based options. The AMA came out and advocated for it. So how are we doing? So this is a little bit of an older picture, but it showed, and I took this from PCRM and the Huffington Post because they had a nicer picture, but they looked at 208 hospitals, and they looked at what is it that we're actually serving our patients and our hospital staff. Well, 20% of the fast food chains first of all, they receive federal funding, and they also have loads and loads of fast food chains inside the hospital, including McDonald's, Wendy's. Five of them had Chick-fil-A. This is a very common picture that I see in my hospital. And these are the things that we serve at our hospital system. Panda Express, Chick-fil-A, Subway, and Wendy's. What do we serve to the employees? What do we serve to people when they walk in the door? Well, there's typically, as I've been told by many food and nutrition staff, I've been told, well, we do offer healthy options. Well, let's see. What is it that we offer on the menu that's good? Okay, well, let's start with what we offer. So we have here pasta with marinara sauce and meatballs. We have grilled chicken, roasted boneless pork loin, meatball sub, cheeseburger, turkey burger, veggie burgers there, chicken breast, cheesesteak. So, these are the kind of foods that we're telling people is okay to eat. Eat a cheesesteak. Does good for you, right? So there was a study that was done that looked at outpatient food options. And what they did was they looked at 39 hospitals in the Southern California area, and they looked at the outpatient nutritional environments and whether they were conducive to healthy eating on a scoring system. So they did a scoring system, and the higher score means healthier eating. So cafeterias, vending machines, and snacks or gift shops scored less than 25% of the maximum composite score, and gift shops, of course, less than 1%. So we're doing really well there. So another hospital menu. So that was outpatient. What about the inpatient menu? So these are the patients that walk in, they get a stent in our hospital, they get put on 5 medications, and we say, hey, you know what? You had a heart attack. Here are your medications. Here's your menu. This is what we want you to eat. Okay, so what should you eat? Well, we've got Raisin Bran and Rice Chex, corn flakes. Okay, so all those refined sugars. We have chicken sausage, pork sausage. We have loads of cheese. We have omelets. We have chicken bacon. We have, pot roast. What else do we have on there? Chicken stir fry. You're getting the point, right? So all of these are the kind of foods that we're serving to our patients after they've had their heart attack. So many of my patients, when I walk in the door and the ICU, when they've just had their stent put in, they're just having their first meal, they're often having a cheeseburger or a steak. So sometimes and this is how we walk in, and nobody says anything. And so, sometimes the meal plans are like the featured meals. So you get this one thing that they really want, and you don't really have that many choices. And many hospital systems do that as well. So what do we have here? French toast for breakfast, chicken parm for lunch, and pot roast with gravy for dinner. So again, has just had a heart attack. This is what I want you to eat. So I started focusing, when I moved to the University of Florida about 6 years ago, I decided that I had enough. I had been sick myself. I was already doing a prevention program and focusing on it, but why wasn't the hospital changing their ways as well? So we started a change, and we started writing about it and publishing about it. And these 2 articles I'm happy to send to you if they're of interest to you, because we did publish on this information. But first we started looking at how is actually an inpatient menu created, because this is actually very interesting, because I didn't know before I started this process how you start an inpatient menu, like who decides all of that. So inpatient meals are created by the Food and Nutrition Department using the diet manual. The problem is there's such a range in what is offered and what's appropriate and not appropriate. So usually it's about 2,000 to 2,400 kilocalories a day. And then the protein, carb, and fat ratios vary significantly. So you can have protein from 10 to 20%, carbs 45 to 65, and then fats about 20 to 35%. That's in a standard diet. And RD is usually involved, but not always involved in the menu planning for therapeutic diets. And JACO really just says about the hospital menu this. They say it should be consistent with each patient's care, treatment, and services. But there are no strict guidelines about how to uphold this tenet. So special diets vary in their restricted macronutrients, sodium, or cholesterol content per hospital. For instance, consistent carb or carb consistent diet varies in its carb composition, but it doesn't tell you how much, and it just usually restricts refined sugars. Cardiac diets have various amounts of sodium, various amounts of cholesterol, but often still have lean red meat, fat, and reduced fat dairy, and very small portions of vegetables. So we started looking in terms of the hospitals and trying to say, okay, can we just survey some of these hospitals and look? So some of these hospitals, we looked at some of the studies that were done, and there was a large consortium of academic hospitals that were surveyed, and they looked at what they were eating. So there was the Healthy People's Guidelines, which talk about eating primarily a plant-forward diet and exercise, movement, etc. And only 4 out of 59 hospitals surveyed met all of the dietary objectives advised by the Healthy People 2000 guidelines. 4 out of 59. Most hospitals met the minimum recommended number of fruits and vegetables and grains, but not enough fiber. And most of the hospitals, or at least half of them, were using fruit juice as a fruit serving. So for specialized low-sodium diets, studies found that the meals were often above the sodium restriction by about 1,000 milligrams per day. So then there was the New York hospital system was also looked at, and again, this is before the new initiatives that are going on in New York City right now. And the Healthy Hospital Food Initiative is very interesting. None of the most of the hospitals in New York were not meeting the fiber recommendations. Sodium content varied from 1991 milligrams per day, or per day in terms of the meal content, to 3248, a huge variation. So then they initiated the Healthy Hospital Food Initiative, and all the hospitals were able to change. So we are able to change as a hospital system. In 2010, the American Dietetics Association, now called the A&D, or American Academy of Nutrition and Dietetics, they issued a statement regarding therapeutic diets and approval process, stating that upon completion of this process, the NCM, which is the formulary of the diets, menus and patient-client education materials must be approved by the hospital medical staff and appropriate hospital committees. So then we thought, okay, who are they, right? So because most of them are the doctors. Well, we're smart, we're doctors, we know what we're doing, right? So we studied that because we thought, okay, we're smart, we know what we're doing, because 10 years ago, I couldn't tell you, other than eating healthy and that plants are important, I couldn't tell you anything. But yet I'd gone through 13 years of training, and I didn't know anything about how to eat until I got sick myself. So we polled the American College of Cardiology. We said, okay, all cardiologists, let's see how you feel about your nutrition education. So you can see here, we talked about the amount of nutrition education you got, and what you can see is that 1% of doctors, the American College of Cardiology, felt that they received a high level of nutrition education that gave them excellent skills for counseling patients. And we weren't doing any better because the FIT, which is the Fellows in Training, said 0%. So the fellows felt that they were actually not even getting any training. So that means over 90% of cardiologists felt that they received little to no education on nutrition in their medical school training and after. So I started at University of Florida, as I said, about 6 years ago, and I walked into food and nutrition services all by myself, just walked in. People have asked me this question many times. Did you go to the C-suite? Did you do this? No, I just met with the dietary staff, and I walked in. I said, I think we need to change the menu. And they looked at me and they said, Dr. Aggarwal, you're from the north, right? And I said, yeah, I'm from the north, I guess. I mean, I'm below the Mason-Dixon line. I was born in Maryland. But they're like, yeah, this here's the South, and we don't like changes to our menu. And so this was a very interesting process because I had to walk in, and I always tell people I'm like a gentle lion. So I like to walk in and say, yes, yes, I understand, but we know that eating more plants is better. So our goals have to be to get people to that. It doesn't matter what people want to eat. We have to focus on what they should be eating and educating them, because people want to change. You see that when you provide people with options and you explain to them how to eat better, they do change. So what were the concerns of the hospital system? Customer service ratings. This was a very real problem and concern. They were worried because poor ratings are very bad for the hospital if you don't have a good hospital food system. No one's going to like the food. No one's going to like eating more plant-forward foods. They were worried about the cost because plant foods are more expensive. They were worried about the viability because food has to sit, because I don't know if you know this, but food is made at like 9 o'clock in the morning for lunch. And so you have to, and it's actually on the trays, and it takes time, and over a couple of hours, it's then transferred out to the patients' rooms. And so it needs to be viable. And they didn't think plant foods would be as viable. Then there was concern that there would be a lack of nutritional content in plant foods. Yep. Then there was a concern about how do we actually do this? There was no standardization of protocols. Physicians didn't understand how to do this. If you ask almost any physician, they have no idea what they're ordering when they order the menu at the hospital. Usually they'll just say cardiac diet, because they have no idea what's in it, and they just click it off on the box. It's usually the intern who has no idea what's going on anyway, having been one myself. So there's a lack of awareness from physicians, a lack of awareness from the nurses. There's a lack of awareness from so many areas, but they're just clicking the box because really nobody knows what's actually happening. So I told you the "You are from the North," which is one of my favorite stories. Really, they really had trouble with me when I first got there. But again, I've always kind. So I started looking at hospital foods. Who had places that had actually worked on a dietary change. And there was only really one other hospital that had done sort of a plant-based menu, and my friends over at Montefiore Osfield was the only other person who had done a plant-based menu. So what we did was we started coming up with meals, and because they humored me. They were humoring me. They said, let's look at some of these meals that you're suggesting. So we pulled out some of the meal options, and we started creating them at the hospital. This took a year. And then we brought in nurses, and we said, let's have a nursing meeting and have them try the foods. And that was probably the most impactful thing we did, because as soon as they ate the foods, we brought the entire CCU in and the telemetry ward, and we brought them in to try the meals. And they said things like, oh my gosh, I can't believe that this tastes like that. This is tofu. That tastes actually really good. I can't believe these vegetables taste so fresh. And so once we started getting all that positive feedback, then people started getting excited in the food and nutrition department that actually maybe we can do this. So what meals became important or highlights? Well, we did simple things like rice and black beans. We had the Boca burger. We did a tofu stir fry, a sweet potato and kale hash, hummus vegetable wrap, a lentil bolognese, and a black bean burger. One of my favorite stories is when Carl Pepin, who is one of the most senior cardiologists at University of Florida, called me and he goes, I just had your lentil bolognese and it was fabulous. And I was like, yes! So the other concern is cost. So is a plant-based meal more expensive, which comes up all the time. People are always talking about how plant-based meals are just more expensive. It's harder or more expensive to eat beans than a burger. Is that really true? Well, so when we looked at the plant-based meals, our meals range from 12 cents a meal to about $2.30, which was about the overnight oats, which I think is a little off too. I couldn't believe that $2.30 for overnight oats. I never pay that much. The cost of a regular cardiac diet or a carb-consistent diet is about $2.20, and the plant-based meals ended up at $2.87. And so about over the 7-month period that we did our pilot program, people ordered about 25 plant-based meals a day. And really, we probably would have gotten way more once we started, and it did pick up once we just got the word out that this was an option. So another question we had was viability. Will these foods actually last? So what we did was we came up with clever ways to do plant-based foods. So we started doing a lot of quick-to-assemble breakfast. We did fruit plates, not fruit plants, but that's funny, whole wheat toast. We also froze a lot of food. So we would batch cook, and then they would freeze it, and then they were able to then use that food later, and it was reheated. These were effective ways where we were able to implement more plant foods and keep the viability good. What about that lack of nutritional content? One of our favorite. We already got some comments like, what? Lack of nutritional content. So we actually went through the menu and went through the nutritional content. Well, if you look at the calories, you can see plant-based menu here, cardiac diet here on the right, and you can see that the calories from the plant diet were lower. You can see that the fat was 24 versus 7.5. Our carbs were about the same, maybe a little bit higher, about 74 for cardiac diet and 81 for the plant diet. The biggest complaint was that our protein was lower. So you can see that the protein in the cardiac diet was 46 and 15 for the plant diet. And we all know that there are many protein sources in a plant-based diet. But the way we were able to negotiate with the hospital staff is augmentation with other sources of protein. Fiber content was a little bit higher in the plant diet, and overall, the cost per tray, as I told you, was about the same, maybe a little higher for the plant diet. But you can see that, if anything, we were better, weren't we? Our calories were lower, our carbs were about the same, our fat was significantly improved, and really the only thing was that, and you can see the fiber was better, and it was just and you can see, of course, cholesterol was zero because plants have no cholesterol. So a lack of standardization. A lot of times what we really needed to focus on is just working with people kindly. So if you come into a hospital system and you act like you're better, you're never going to win. You really just walk in and explain to people, and the RD staff tends to be amazing. And so I encourage you, if you have some interest in doing this and being involved in this, to talk to the RD staff, because they know that they've just also been part of the system sometimes for so long, or they don't know that it's possible to make these changes. And sometimes just having this conversation with the registered dietitians at the hospital really can make impact. And really just putting people on your side, getting a bunch of the nurses to come in, try the meals. I don't know. I've had so many people come to me and say, well, you really need the CEO involved in this project. I said, I don't know if you do. I mean, I walked in and just met with the staff and explained to them that this is the way we have to eat. And once everybody saw the data and saw the way the changes, how important it is for health, they just did. I didn't get the C-suite involved. And to this day, I have not talked to the CEO about the hospital menu changes we made. So we also changed the ordering protocols. That was maybe the hardest thing to do, which is that we just figured out how to use Epic to put the menu in. I had to meet with 25 different people just to figure out how to put a plant-based menu on the menu schedule. But once you do it again, all these processes are painful but worthwhile. So this is our plant-based menu, one that I'm very proud of. You can take pictures of it. You can also ask me for it, because many hospitals in the country have asked me for this menu, and they use it when they talk to their own hospital systems, which I think is awesome. So not only did we do that, we also changed the way there's the discharge education. So imagine, I said the first time the person comes in and says, sir, you've had a heart attack, you've had a few stents put in your heart, here are your medications, go to cardiac rehab, good luck. Well, we all know that the depression rates are extremely high in patients after heart attacks, which is associated with higher rates of morbidity. We also know that the morbidity just from the heart disease in that first 30 days is extremely high. And then we just say, good luck, take care of yourself. And what happens to that patient? Well, the patients come to me, they're scared, they're so nervous. So we changed that. We said, okay, you know what, sir, you've had a heart attack. I'm so sorry. You've had stents in your heart. Here are your medications. We've got you. This is what we're going to do. You're going to eat off of the plant-based menu. You're going to watch these videos. So we started putting videos on the screens in the hospital patient rooms. And we gave them a discharge education packet, which I'm also happy to share with you, which is 10 pages long. That talks about stress and sleep and movement and exercise. So we say to the patients now, we got you. We're going to make you better, because we're going to provide you with tools to heal your own body. So there's our discharge education packet, again, that I'm happy to share with you. But we also started doing education projects where we started doing culinary CME, so things similar to what this program is, which I love, which is that we started doing education for physicians. The first one was in 2020, right before COVID, and we're just about to do our next one this summer, because we think that physicians and allied professionals and nurses are the key to the change. If we eat this way and we tell our patients that this is good, healthy eating, then our patients will listen to us, because we have experience. We know that these foods are good for us. So here's a quick video that I was going to close with of how we implemented the plant-based menu at University of Florida, and then I'm happy to take questions. Oh, we're doing questions at the end, actually. If you could start the menu, start this. Or do I? Oh, I do. Well. That's not the music. That's very funny, though. Are you working on that, or am I supposed to do something? Okay. Sorry, guys. Yeah, I'm so glad that you're here because I would be like, I don't know what to do. We're not watching the video today. Hi there. How are you? Monica Aggarwal. Nice to see you. So I've been in practice for 10 years, and I would admit that I've given out more Lipitor and Crestor prescriptions than most people because as a cardiologist, that's what we do. What I found that is I kept feeling like I was just giving out more and more medicine, and yet I wasn't making people better somehow. And I also, like many people, feel that, what am I doing here? We as physicians are taught to tell people, well, eat better and exercise more. But we don't really tell people or give doctors the tools so that they can then counsel their patients better. And so what we're trying to do is change that model. I want people starting to realize that even as employees and staff of the hospital, that what you eat matters. The things that you do when you're young impact your whole future. Start changing your habits now and you'll be able to walk better longer. Your joints aren't going to hurt. You're not going to be a 30-year-old with diabetes. All of these things change if you just make the first step now. So about a year ago, Dr. Aggarwal partnered with myself and the food nutrition team to conceptualize the introduction of a plant-based menu, specifically to start out with our patient population. We have really researched the benefits of introducing plant-based foods into daily cuisine for not even just our cardiac patients, but really our population as a whole and some of the preventative benefits it does have to health. And then what we did was really work very closely, again, with our clinical team, with our culinary team to design a plant-based menu that really does meet the food preferences of our population here in Gainesville, Florida.
We sat down multiple times throughout the past year, kind of brainstormed, developed different menus, different ideas.
We conducted meal tastings, including our nursing staff as well as some other staff members in the organization to get their buy-in and to tweak our recipes. You get the dietary staff involved and you get them excited about it, and then you start teaching the nurses about what the food is and letting them taste it, and then they then tell the patients, like, I tried this is really good, and then the patients start feeling less intimidated and less fear. Sometimes when they look at the menu and they're a little bit hesitant to try something new, but once they do receive that meal, they're pleasantly surprised with the taste and the flavor of it. I think it's important to remember that we're not feeding people just lettuce. We're giving people fabulous food. It tastes good. There's different types of flavors.
We do a sweet potato kale hash. We do a lentil bolognese over pasta. We do a tofu vegetable stir fry.
Our next phase is to really start incorporating the plant-based items into our retail operations, such as our cafes, to really promote this same initiative and this same healthful philosophy to our employees and our visitors that come in our door every day. Let's do this together. Let's not be afraid to make a little bit of a change in your hospital. It takes small steps at the beginning, but I'm confident that we can do it as a group. You might have some people who might tilt their head a little bit when they first hear it, but I guarantee if you work through that and again, if you bring it to them and really engage them in the process, it can work. It can work, and it does work, and it really does make a difference. People often say that it's hard to change or that people can't change and it's just easier to give out a medicine. Boy, I hear that all the time, sometimes every day. I don't agree with that. I think that change is hard, but change is good, and that it takes time. But I think that we underestimate sometimes what people are able to do. And so sometimes when you give people the tools, they will make the changes. Not always immediately, but they slowly do. Our job is to just start the process. Thank you so much. So I just like to say, because it's sort of fun, is the person who was my biggest cheerleader at the end was my biggest naysayer at the beginning. And she was the one who was like, Dr. Aggarwal, you're from the north, right? So, I guess the thing is that you make friends in places you don't realize, and sometimes if you just put that extra effort in and work with them, they will make the changes. We have a beautiful menu at University of Florida. So thank you so much. Here's my contact information if you have any questions.